So with every ventilator, the first thing you want to do is a circuit leak test to make sure that your circuit is okay, there's no holes in it, everything's working great. So with this ventilator, if you hit resume current, it's just going to go back to the settings you were on before you turned it off. We don't want to do that because we have a new patient, okay? So we hit new patient, and then you're going to say patient accept, and it brings you to this screen. The nice thing about this ventilator is we can do any patient size. So if we were in the NICU, we jump over to neo. If we were in the PICU, we jump over to pediatric. You guys are starting with adults, so you're always going to do adult. And I think they do these steps before they bring them up to the unit. So ask when you guys start clinicals, but I think when you actually get into the unit, you don't have to do these steps. The cleaning equipment people do it.
Gotcha.
But we need to know how to do it, right? So you hit adult, you hit size accept. It brings you to this screen. Your EST, or extended system test, is how we do our leak test. So you're going to hit that button first, EST, and it gives you some instructions. We want to make sure that we're not hooked up to a patient because it's not ventilating right now. And then what we do is we need to block the Y. So if one of you would like to take and block the Y, make sure you hold pressure on that. And then the next thing we're going to do, if it's easier, you can take it. And we'll go ahead and hit continue. The first two pieces are a leak test and a compliance test. It's filling the circuit up with air, and then it's going to check to make sure there's no leaks anywhere, and it's going to do some calculations to figure out what the compliance of the circuit itself is before we hook it up to the patient. They both pass, so now you can let go. Next is the O2 sensor calibration, and it'll fail because our O2 sensor is expired, and they're really expensive, so we're not replacing it. We'll go ahead and just move this over here. But in the real setting, obviously, you would want all three of those things to pass. If they don't, it depends on, if you've got time, maybe try to do it again. If it's an emergency, swap it out for another vent and have somebody else look at it later, right? So obviously, this is something that we want to have done before our patient arrives, because if we're standing here waiting for 90 seconds to pass,
right,
your physician's yelling at you, your colleague is bagging and glaring at you because it's taking a while.
You don't want to use anything that fails on automation. Some things are easy to fix, you might be able to fix it yourself. Some things might require, like the transducer. If the transducer is bad, there's nothing I can do about it. It's about manage. Like the battery, these are the batteries. So if he has spare batteries, we just pop one out and pop it in. Pop it in. And these batteries.
And we wouldn't want to be hooked up to a patient right now because the ventilator's not feeling it. And during the O2 sensor calibration, what it does is internally it cranks the FiO2 up to 100, makes sure that it hits 100, it cranks it back down to 21. It's just zeroing and calibrating that oxygen sensor. So it failed. Again, it's probably just expired. Again, alarm silence. You'll see I keep hitting up here. The other kind of cool things within this box, we can actually put in the size and length of our ET tube. I don't think they use that feature at Toledo Hospital, but it can help give you some more calculations if you do some of the advanced calculations with this machine. Patient weight is also an option that you can put in there. In pediatrics, we use that pretty frequently because we actually look at the tidal volume per kilo that we're getting, and that'll display right on the screen because the machine can calculate that for you. You don't have to take any time to do that. In adult land, you really don't look at tidal volume per kilo because it doesn't matter that much. You're more looking at overall volumes.
Gotcha.
So again, you probably won't use any of that stuff there. Typically, your normal day, you're just going to do that EST. The circuit compliance will actually display the number that it found when it did that test. So if you start the machine and it says 0 there, or it has stars there instead of numbers, you know that that circuit compliance test hasn't been done, and you need to do it before you hook it up to your patient. Still with me? Mm-hmm. All right, so we're going to do set up accept, and this is going to get us back to this screen. Now we're ventilating, so now we can put our patient up here. I just tell everybody, you don't know what you're doing, don't get into that sort of thing. Alright, so we're going to start up here and just work our way around the screen first, and then we'll start playing with some modes. So the first thing you'll see is as we're alarming, it's red here and we've got this flashing icon. If you click on this arrow, you can see all of the other alarms that have recently gone off. If you hit alarm reset, you can clear everything that's not actively alarming. I'm going to do something really quick just to get rid of that because it's going to drive us crazy if I don't. There. Alright, so back over here. So again, alarm silence, this will go for 2 minutes and then it'll time itself out. Alarm reset just clears anything that's up in that corner, now it looks a lot prettier. Alarm limits gives us all of the alarms that we're going to set ourselves. So as you go in and you want to change things, you can do that by clicking on it, and then you have to click it one more time to accept. If I change it and then I jump over to something else, it goes back to what I had done before. So you really have to make sure you either touch it again to accept it, or you can hit accept down here. Oops. See, so there's two ways to accept it, right? Click it again and that gets rid of that screen. Down here you can actually give manual breaths, and what that does is every time I push this button, it'll deliver another mechanical ventilator breath. So I could hit it a whole bunch of times in a row if for some reason I feel that they need more breaths. Clinically, the only time I've really used that button there is if, like especially in the NICU, if I've got a kid whose saturation is just kind of dipping a little bit, I might give them just a couple extra breaths and it'll bump them back up and they're fine. That's cool. In adult world, I've really never used it. If they need extra breaths, they usually need to be bagged and there's something else going on. So that's one of the features of the med. This suction button, I'll show you. All this does is it hits alarm silence and increase FiO2 at the same time. So instead of coming up and saying, okay, I want silence and I want to increase O2, all you have to do is hit the button, they'll both come on at the same time. So it doesn't do anything else, it just does those two buttons at the same time. They're both a 2-minute timeout. Increase O2, you can do that on its own if you like. That'll always go up to 100% FiO2 every time for 2 minutes. I'm going to turn this down so it doesn't overlap.
Will you see it here if it?
Nope.
No. Okay.
As long as that light is on, I know I'm on 100% FiO2.
Okay.
Well, after that 2 minutes is over and that light goes off, I'm no longer on 100% FiO2. Or you can click it off before that 2 minutes is up.
Gotcha.
You've seen we use this to dial numbers in. So if you want to crank that up, crank it down, accept or cancel. So let's say I went up to 30 and then I go, oh wait, I didn't want to do that. I click cancel and there's right there. Your auto peep and your plateau pressures, we can do that with our inspiratory holds and our expiratory holds, right? So if we do an expiratory hold, we can find out what our auto peep is. I'm going to wait and let them do a breath. And I'm holding this button down. And I usually hold it for at least like 4 seconds there and then let go. And now you see we've got a number here instead of stars. So that's your expiratory hold. And you have to kind of watch the screen and time it when they're exhaling. Obviously, the blue flatter line is your expiratory phase, and that red section is the inspiratory phase. Now, for your plateau pressure, it's the opposite. It's an inspiratory hold. So now they're inhaling, and I'm holding. And now with this next breath, we'll get a plateau pressure. There's another way to do an auto peep, and I'll show you that when we get there. This just helps you visually see what size patient you have. The print button, if we were plugged into a printer, you could actually print things right off of the screen, so you could show somebody what the screen looks like. I've never seen a hospital use that feature. Panel lock, you can do that if you have a handsy nurse who keeps coming up and changing your FiO2 without telling you. And if you've got family members that are adjusting these. We had family members that had a home vented patient. They were so comfortable with the vent settings, they were actually coming in and they were adjusting things if he would desat or what have you. And obviously that's dangerous because we have no assessment around that time. So you just hit that button and now nobody can come in and play with that screen. You hit it again and it's unlocked and you can play with the screen again.
Does it have like a timeout setting or no?
It does not. As long as that light is on, it's locked. Setup will take you back to that beginning screen. Once it's on the patient, I don't see you really ever needing to get back to that screen, unless maybe you wanted to document what the circuit compliance is or something like that, right? And you set up accept, and it'll get you back out of there. There are some advanced settings on this machine. Anything that has this little yellow triangle in the corner will get you some more settings that you can play with. You can change your rise time. I think you guys have probably talked a little bit about that. You'll talk some more about that later on. You can change your your waveforms from square wave to decelerating. Another big thing, you can change your bias flow within the circuit. That's just that leftover air hanging out in the circuit. If you've got a patient who's trying to breathe a lot above the vent, you can give them a little more bias flow, might make them feel more supported. If you have a patient that's having a hard time triggering the vent, maybe decreasing that bias flow could even help make it easier for them to trigger.
So is it like it's like a sensitivity kind of thing?
It goes along with sensitivity, and it's just the amount of movement going on within the circuit, aside from your inhalation and exhalation. So that's the advanced setting button. The mode button, so you can either change your mode by touching the mode, or you can change the mode by hitting the mode button. Either one of those options will get you to this screen, and you can choose whatever mode you'd like to be on. So obviously we can do our volume AC or SIMV. You can do your pressure AC or SIMV. You can also do these PRVC. I don't think you guys have talked about that yet, but it's kind of a hybrid mode where you target the pressures high and low that you want, and you target the volumes about that you want, and it'll kind of adjust and get you within those targeted. So it kind of gives you the best of both worlds, best of volume and the best of pressure. I'm not going to talk about APRV because it's a more advanced mode, and I don't know that you guys even talk about it this semester. You can also put the patient on CPAP. So if we were checking to see if they're ready to wean, we might, part of our protocol might be to have them in CPAP for a couple hours and see how they do. So once you've chosen your mode, you hit mode accept, and it'll go to the settings that you've got in there. An event, this is a feature that I've not seen anybody use around here, but basically what you can do is kind of mark the record within the vent that you did a blood gas, or you suctioned, or you intubated, or whatever, right? It doesn't transfer over to the computer, it just saves it in the machine, so I don't think we're really ever going to use that, but that's what that button does. Freeze, I'll get to in a minute. Screens gives you this option, and there's a bunch of different screens we can do. So the main screen is the one we've been looking at all along, and you can get there either by hitting main or by going to screens and hitting main. Another screen you can see is the loops. You get your flow volume loops, you get your pressure volume loops, and you can look at those. And if you don't like the way it looks, you can adjust the scale and get a better picture of what the loop looks like. Another thing you can look at is this monitor screen that gives you all of those read or calculated values. So everything you're setting is down here, and everything the machine is reading is up here. I like to use this screen when I do my vent check because it has all my numbers up in front of me.
And that's the monitor screen?
Yep. Okay. And you can adjust all of these. So any one of these, if you would rather have your respiratory rate, the first thing, you could make that the respiratory rate. And you just do that by touching it and changing it, right? Trends is a cool screen. I like to use this when we're rounding. So let's say you had your patient yesterday. When you left your shift, they were on 21% FiO2. You come back and they're on 100%. What the heck happened? You can hit freeze, and then you can scroll through time and see what the patient's done all night long. So you can see all these columns. Obviously, it hasn't been on, so we don't have any numbers, but all these columns will record minute by minute what every number was. So we could watch our FiO2 column and see, this is jacked up because our O2 sensor doesn't work, but we could see like maybe at 4 a.m. they went from 21% to 100%. Let's look back through the chart and see what happened at 4 a.m. Oh, they were drawing a blood gas. I bet they turned it up to 100 and then forgot to turn it back. Or it could be, you know, they've gone up by 5% every hour or so all night long. This was a really gradual change. What's going on with our patient? You can look at peaks, you can look at any one of the parameters, and again, you can change which parameter is in which box just by touching it and adjusting. Right? So this really gives you a good idea, minute by minute, what's been going on with your patient.
So why do you need to hit the freeze button? Like,
for whatever reason, it doesn't scroll unless you hit the freeze.
So it doesn't do anything like with the air going to
nope,
the patient?
The patient's still being ventilated like normal. You'll see it's still continuing to breathe. Maneuvers, you can do a couple of maneuvers. I don't know what the complex is. I don't remember. I've never used it. The ones that you might actually see in use are the maximal inspiratory pressure, and this is probably going to be used if you're ready to extubate but you want to see what maximum pressure they can. NIF is another one, the negative inspiratory force. It's the same thing. So it's going to give you a negative number, but they have to be spontaneously breathing, and I'll try to do it with the machine. We'll see what happens. But what you would do is you would hit start and you'd say, okay, sir, please take a big deep breath in. And they take their big deep breath in. And now we've got a number there. And so if that number's nice and high, like a negative 29, negative 30, that's pretty decent. They're probably going to do okay if we extubate them. If they can barely generate any force when they take that big deep breath in, we maybe need to hold off and not extubate them.
So when you click start, it like pauses it.
It pauses the vet, yep. So nothing's happening once you hit start, and you have to. They have to take a breath. So again, if they're not spontaneously breathing and they're not following your directions, nothing's going to happen here, and eventually it'll time out and go into the apnea mode.
Okay.
So that's one thing that you can do. And the other maneuver that you might do, you can do your auto peep right from here. So rather than sitting here and watching and holding your expiratory hold down, you just hit start and it'll time it whenever it's ready. Oh.
And this is time state.
And then the auto peep will pop up once it gets its calculation. Let's see. Standby is nice if you've got a patient that needs to go to CT scan. You pop them off the vent, you get them on their transport vent, you just hit standby yes, and now it's not doing anything, it's not alarming, and we can just leave it sitting in the room by itself. Patient goes off to CT, they get their procedure, they come back. Once you pop them back on the vent, you hit the resume, and it immediately goes right back to the same screen you had been on before you hit standby. Same settings, same everything, it'll immediately kick back in. Utility, you're probably not ever going to use. This is more like the internal functions of the vent. Like I disabled our O2 alarm so it stops alarming at us. If I enable it, it's screaming at me because our sensor's bad, right? So you guys probably aren't ever going to use this screen. The one time I did use this screen a lot in pediatrics, we actually would change that increase FiO2 button. This tells the machine what to do when we hit this button. So right now it's at 79, meaning if we're down even as low as 21%, we always hit 100% as soon as we hit that button. Let's say we only want to go up by 20% when we hit that button. We'd adjust that there, and now every time I hit this button, it's only going to go up 20 points from where it was before. In adult land, it's pretty rare that you have a patient that you don't want to have 100%. In pediatrics, it's pretty often that you have patients you don't want 100%. The rest of that's all like internal computer kind of stuff. All right, so from here, let's go ahead and put in whatever mode you guys are comfortable with. If you want to stay in volume AC, if you want to put it in pressure, what kind of settings do you want to put this patient in? Let's say it's an average adult male, 6 foot tall. What do you think?
Probably volume or pressure, assist control. Either or.
Now you can go through, and again, these are all your set parameters, so go ahead and adjust them if you like, whatever you want to put your patient on.
If you want to...
So either that or you click accept.
Yep.
What are like the red arrows in between?
So
each?
that
Is that
is,
saying like...
it's a visual reminder of what your alarms are set at. So let's crank this down to 16. 15 even. And now you see that high alarm.
Okay.
They're right on top of each other. Oh, we better pull that back out. Okay, now I've got some space. Okay. So it's just a visual reminder of where your alarms are. And we'll do all these settings first and then we'll play with the alarms.
And then it'll go back to whatever you had set. Okay.
You usually just keep that at 1, right?
And on this ventilator too, I want to point out, so here's where you would adjust your eye time, but you can also see it down here, inspiratory time, expiratory time, and eye to E ratio. Okay. So if you want to watch your eye to E ratio as you're playing with eye time, it's usually right there.
While you're doing the treatment.
I don't even know what to set everything at.
And you can even just play with it, it doesn't really matter at this point. I think Toledo's standard peak is 8. I think I've heard.
I think that's what she said.
Yeah.
Max, it's still water. Put this little cup in.
And the flow triggering, so that's going to be, anytime you hear the word trigger, that's something that triggers a breath, something that will start a breath. So in this ventilator, in this mode, it's the flow, so how much flow the patient pulls through that tube to get it to trigger a breath. So he's got to pull a whole liter worth of air to get it to trigger a breath. And we're probably only getting,
So once it's hooked up, it can say hooked up. All you do is drop your overall with a syringe.
we're only pulling about 0.36 right now. So he'd have to pull almost, well, 3 times the size breath that the machine's giving in order to trigger a breath. So we'd probably want to turn that down a little bit. The more you turn it down, the easier it is to take a breath. The more you turn it up, the harder it is to take a breath. So if you find that every time your patient even moves a little bit, it triggers a breath, you want to turn it up a little bit, right? If you find that your patient's trying to take a breath and nothing's happening with the machine, you want to turn it down a little bit.
Okay.
And they might have a standard starting point that they use for that, I don't know. Okay, yeah. Do you want to do the alarm limits then too?
So with like the V60, is it kind of like the same to where you'd want like, I know we didn't touch something that was 20.
Yep, so apnea interval pretty much is always 20. If they've gone 20 seconds without taking a breath, we should probably take another breath.
And then for PEEP, like...
PEEP we usually do about 2 below. Yeah, so whatever those standard alarm settings she's told you, those are pretty...
kind of the same.
And you'll want to use those numbers always per test. But if you get into Toledo and they say, oh no, we always set our low PEEP at 5 below, follow that one. Right? They might have standards for some alarms, they might not have any standards for any alarms. If they don't have any standards, just follow what Chris just told you for class. Let's see, if we're going this way, we've got our low and high peaks, and right now we're hitting about 24. And those, I think, isn't it about 10 above and 10 below? Not too much? I can't. I'll have to ask her before we check out, because I don't know anymore.
We'll just go for that.
So what do you guys put for mode?
He didn't accept it yet.
Mode automotive, it's like cross that.
Okay, no, it's a slash. Not a slash. So I would just put VC. That's fine. If we use auto mode,
and so your total, this is VE is minute ventilation. So let's find on this machine, it's called total VE. So that's at 5.1 right now. And I think that one's like 2 above and 2 below. Because minute ventilation isn't going to swing real big.
We're going to have CPAP. Nope. Draw a little line in that quarter box. We have the box. Okay? Okay, so then the pressure control, pressure support, we don't have either one. We draw a line and hold it.
That would only be put in we're using.
Right.
What else do we got? And then we pull up our exhale tidal volume again. So we can see that. That one, I think, is about 50 above and 50 below, and 50 meaning like 50 mLs. So most of these machines you're used to hearing 360 instead of 0.36, right? So 50 above would be like 0.41, right? And we can adjust that. Let's say we've got our 6-foot male. Do you really want him breathing only 360? That's not a whole lot, right? What would you rather have him closer to? Sure. How are we going to do that in this mode?
Okay, sidewalk will be over here in the unit.
So with pressure control, we'll adjust our volume by adjusting what number? Yep. So go ahead. What are you going to do to get the volume higher? What are you going to do with that number?
Increase the pressure.
I buy them the babies sometimes.
That's probably a good start. Let's watch and see what we get. We might take a breath or two to really There we go. Perfect. Right at 5. That's much better.
So then you would maybe do like 7 or something?
That's fine. Yeah. That way that gives them the opportunity to take like a really big sigh breath. And then for low, for that, I'd probably do like 0.4. Something like that. Even 0.35 would probably be okay. Because you want to know if it drops drastically.